ओके, आज की हमारी गेस्ट स्पीकर है डॉक्टर सुमना कुमारी पांडा मैम का मैं एक छोटा सा इंट्रो दे रही हूँ। इन्होंने एमडी किया है, वर्तमान में जिला होम्योपैथी चिकित्सा अधिकारी हैं, कटक सर्कल, कटक स्वास्थ्य एवं एफडब्ल्यू विभाग ओडिशा सरकार के रूप में कार्यरत है। धबलेश्वर होम्यो क्लिनिक कटक ओडिशा में सभी प्रकार के पुराने मामलों, विशेष रूप से प्रसूति एवं स्त्री रोग संबंधी मामलों, कैंसर के मामलों में उपचारात्मक देखभाल के लिए 35 वर्षों का होम्योपैथिक क्लिनिकल अनुभव है। डॉक्टर अभिन्न चंद्र होम्योपैथिक मेडिकल कॉलेज एवं हॉस्पिटल भुवनेश्वर में मेटेरिया मेडिका विभाग में 18 वर्षों का शैक्षिक शिक्षण अनुभव है इनका। रिसर्च सीसीआरएच भारत सरकार के तहत सहयोगात्मक अनुसंधान परियोजना प्रसव की अवधि पर होम्योपैथिक चिकित्सा की प्रभावकारिता में प्रधान अन्वेषक के रूप में काम किया है इन्होंने। सीसीआरएच नई दिल्ली एवं स्वास्थ्य और परिवार कल्याण विभाग द्वारा आयोजित विभिन्न प्रेरण प्रशिक्षणों, कौशल विकास प्रशिक्षणों, पुनर्अभिविन्यास प्रशिक्षण कार्यक्रमों, एचएमओ समुदाय के जागरूकता कार्यक्रम में संसाधन व्यक्ति हैं। सरकार ओडिशा के LIGA, IIHP रिसर्च सोसाइटी ऑफ इंडिया, आंध्र प्रदेश होम्यो एसोसिएशन, तमिलनाडु होम्यो एसोसिएशन और ओडिशा के कई अन्य संगठन द्वारा आयोजित राष्ट्रीय अंतर्राष्ट्रीय होम्योपैथिक सेमिनारों में विज्ञापन, पेपर प्रस्तुतियां हैं, इनका प्रकाशन है। IJRH, पबमेड आदि जैसी पीयर समीक्षा पत्रिकाओं में लेखन प्रकाशन है। ओडिशा के सर्वश्रेष्ठ हैंडीमैन के रूप में सम्मानित किया गया है इन्हें। हैंडीमैन प्रतिभा सम्मान 2014 में ओडिशा के होम्योपैथिक बोर्ड द्वारा सर्वश्रेष्ठ होम्योपैथ मारवाड़ी महिला समाज द्वारा कोविड वॉरियर, लायंस क्लब द्वारा वीमेन ऑफ इंस्पिरेशन, ओडिशा नारी सेवा संघ कटक शाखा द्वारा सर्वश्रेष्ठ महिला सामाजिक कार्यकर्ता, भारत होम्यो रत्न, वेल्सन होम्योपैथी आदि द्वारा इन्हें प्रदान किया गया है। पूरे ओडिशा में मधुमेह जागरूकता पैदा करने के लिए लायंस क्लब इंटरनेशनल के माध्यम से मधुमेह अध्यक्ष के रूप में सेवा की और 2018 में सबसे प्रतिष्ठित अंतर्राष्ट्रीय पदक प्राप्त किया। सो मैम, आपका IFPH मंच पे बहुत बहुत स्वागत है। आज का आपका विषय है पीसीओएस हाइपर प्रोलैक्टिनिया के कारण बांझपन के लिए केस स्टडी। सो मैम, आपका फिर से दोबारा बहुत बहुत स्वागत है। ओवर टू यू मैम।
थैंक यू मैडम। मैडम, मेरा एक प्रॉब्लम अभी है कि ये स्क्रीन मेरा लैपटॉप का आधा में आता है, फुल नहीं होता, कैसे करूं?
उसको आप मैक्सिमाइज कीजिए।
ओके ओके ओके, हाँ हाँ,
कॉर्नर में आपको मैक्सिमाइज
हो गया, अभी हुआ। पहले थैंक यू वेरी मच डॉक्टर दीपमाला।
स्क्रीन शेयरिंग आपने नहीं किया है, आपने पहले स्क्रीन शेयर
करूंगी, अभी कर लूंगी।
ओके ओके।
तो पहले आपको बहुत बहुत धन्यवाद और IFPH को भी बहुत धन्यवाद और मेरे टीचर डॉक्टर MK शाहनी का मैं आभार व्यक्त करती हूँ। सो रियली डॉक्टर दीपमाला, बहुत दिन के बाद आपको देखा, 2-3 साल हो गया गया सेमिनार के बाद।
हाँ, 3 साल हो गए मैम।
हाँ, अभी मैं रियली जिला होम्योपैथिक चिकित्सा अधिकारी से मैं लास्ट 29 फरवरी 2-3 दिन पहले मैंने रिटायर्ड किया गवर्नमेंट जॉब से, स्टेट गवर्नमेंट की जॉब से। सो मैं अभी प्योरली प्रैक्टिशनर ही हूँ धबलेश्वर होम्यो क्लिनिक में। सो अभी हमने रियली आज का मेरा एक केस स्टडी है। ये जो केस स्टडी मैं शेयर कर रही हूँ, रियली ये इसी पेपर को मैंने लीगा का इंटरनेशनल सेमिनार सरेंटो इटाली में प्रेजेंट किया था और ये बहुत हाई अप्रिशिएशन में गया था। इंडिया से हम बहुत सारे स्पीकर्स थे, उड़ीसा से 3 थे, प्रोफेसर LK नंदा थे, प्रोफेसर निर्मांती थे और माई सेल्फ में थी, 3 उसमें 2019 सितंबर में था। सो मैं अभी स्क्रीन शेयर कर रही हूँ। So my topic is PCOS associated with hyperprolactinemia एंड इनफर्टिलिटी, ए केस रिपोर्ट। हमें ऑडिबल में सबको सुनाई देती हो?
ऑडिबल बट योर स्क्रीन इज नॉट शेयर, आपका स्क्रीन शेयर नहीं हुआ।
तो कैसे करें?
आपका शेयर का ऑप्शन होगा मैम, स्क्रीन शेयर का ऑप्शन होगा आपके स्क्रीन पे।
ओके ओके, ठीक है, मैं देखती हूँ प्लीज। हाँ हाँ हाँ, भूल गई, राइट। फिर भी नहीं आया? न्यू शेयर में करूँ क्या? ओके,
शेयर, आपका स्क्रीन शेयर हुआ है मैम।
हुआ?
हाँ
मेरे
शेयर,
को दिखता नहीं हो?
हाँ दिख रहा है, आप दिख रहा है आपका
भी
स्क्रीन
दिख
शेयर।
रहा है ना?
हाँ हाँ
ठीक है। सो PCOS एसोसिएटेड विथ hyperprolactinemia and infertility, a case report.
या
Really, hyperprolactinemia, PCOS, हमको बहुत टाइम PCOD के बारे में हम सबको पता है और ज्यादा उसमें जाने की जरूरत नहीं। लेकिन जब PCOD PCOS में कन्वर्ट होता है, उसके साथ कई सारे हार्मोनल प्रॉब्लम्स आ जाते हैं, बहुत सारे प्रॉब्लम्स उसके साथ आ जाते हैं। जैसे हमारा उसमें ओवरियन रिजर्व कम होता है, अनोवुलेटरी साइकिल्स होते हैं, तो साइमल्टेनियसली हाइपोथायराइडिज्म आ सकता है, हाइपर इंसुलिनेमिया आ सकता है, हाइपर प्रोलैक्टिनेमिया आ सकता है और हाइपर एंड्रोजेनिज्म भी आ सकता है, जेनीमिया, हाइपर एंड्रोजेनीमिया भी आ सकता है। सो ये सारा हम देखते हैं। तो और पीसीओएस में ओवरियन रिजर्व कम होने से एंटी मुलेरियन हार्मोन बहुत ही कम होता है। अगर पीसी ओवरियन रिजर्व थोड़ा बहुत चलेगा तो उसमें एएमएच भी बहुत ज्यादा भी होता है। सो ये सारा प्रॉब्लम उसके साथ पीसीओएस में एसोसिएटेड हो जाता है। लेकिन मेरा ये केस रिपोर्ट में जो अभी शेयर करने वाली हूँ, इसमें प्रोलैक्टिन लेवल बहुत ज्यादा था एसोसिएटेड विथ पीसीओएस। सो ये केस रियली, एक लड़की थी, वो लड़की जब अनमैरिड थी तब हमारे पास आई थी पीरियड्स प्रॉब्लम के लिए, मेंस्ट्रुअल प्रॉब्लम के लिए, और उसका पीसीओएस डिटेक्टेड हुआ था। फिर बाद में उसका शादी हुआ और वो इनफर्टिलिटी उसको आया, उसमें निकला, तो वो फिर हमारे पास बहुत साल के बाद आया। उस तब भी उसको हाइपर प्रोलैक्टिनेमिया था और सेम मेडिसिन कैसे जाता है, थी एक सीरीज में, वो जाने के बाद वो कंसीव किया। यही हम आज प्लेस करेंगे। सो कमिंग टू द इंट्रोडक्टरी पार्ट, क्लाइमेट चेंज इज द प्लैनेट्स बिगेस्ट थ्रेट इन द 21st सेंचुरी। रियली ये बात बहुत बड़ी बात आजकल हो गया है। दो पीसीओडी इज जेनेटिक, स्टिल देन इफ वी कैन मैनेज आवर लाइफस्टाइल थ्रू हमारा स्लीपिंग हैबिट, हमारा एक्सरसाइज, हमारा डाइट हैबिट, ये सारा को हम यदि नजर में रखें और हेल्दी मेंटेन हो, तब वो जेनेटिक होने पर भी वो लैटेंट स्टेट में पीसीओडी रुकता है थ्रू आउट द रिप्रोडक्टिव एज। फिर मेनोपॉज के बाद उसका बात ही खत्म। लेकिन हम उसमें मैनेज नहीं कर सके, हमारा डाइट हैबिट, हमारा स्ट्रेस लेवल, हमारा एक्सरसाइज, डेली एक्सरसाइज या स्लीपिंग हैबिट, ये सब हम मैनेज नहीं कर सके, तो वेरियस टाइप्स कितने सारा हार्मोनल प्रॉब्लम्स आते हैं। उसमें डायबिटीज भी हो सकता है, हाइपोथायराइडिज्म भी हो सकता है, और लेडीज गर्ल्स में पीसीओडी भी हो सकता है। पीसीओडी ज्यादा दिन कंटिन्यू करता है तो उसको पीसीओएस में कन्वर्ट होता है। तो ये सेम थिंग है, एक्सट्रीम वेदर कंडीशन, हीट स्ट्रेस, ऑल्सो ये कुछ कुछ फैक्टर्स है पीसीओएस को ऐड करने के लिए। और भी एक फैक्टर है, मैं बोलूंगी कि प्लास्टिक, यूज ऑफ प्लास्टिक। मैंने रियली इंडियन क्लाइमेट कांग्रेस में ये पेपर प्रेजेंटेशन दिया था, एज ए रिसोर्स पर्सन कि पीसीओएस कैसे रिलेटेड है प्लास्टिक के जरिए से, प्लास्टिक कैसे उसको ऐड करता है पीसीओएस होने से। क्योंकि प्लास्टिक में जेनो एस्ट्रोजन करके कुछ होता है, तो वो फॉल्स एस्ट्रोजन है, वो एस्ट्रोजन की तरह बिहेव करता है। तो एस्ट्रोजन लेवल बहुत ज्यादा बढ़ जाता है बॉडी में जेनो एस्ट्रोजन की तरफ से, और ओवरियन सेल्स उसे समझ नहीं सकती, तो पीसीओडी लाइक बिहेवियर फाइनली आता है। वो एक लंबा चैप्टर है, हम उसमें नहीं जाएंगे, लेकिन प्लास्टिक भी कंट्रीब्यूट करता है पीसीओएस के लिए। So polycystic ovarian syndrome is one of the most common hormonal disorders among women of reproductive age. PCOS is common and complex endocrine disorder in the women worldwide. So PCOS क्या है? This is a multifactorial disorder. उसमें बहुत सारा फैक्टर्स रहते हैं, जैसे मैंने बोला जेनेटिक फैक्टर है, एंडोक्राइन फैक्टर है, एनवायरमेंटल फैक्टर्स है। और देख मोस्टली पीसीओएस क्यों इतना इम्पोर्टेंट है, आजकल पीसीओएस के ऊपर सारी जगह चर्चा है, बहुत सारा सेमिनार्स है, बहुत सारे डॉक्टर्स उसके लिए कंसर्न है। तो क्योंकि वो इनफर्टिलिटी की इंसिडेंस इंक्रीज करता है और प्रेगनेंसी कॉम्प्लिकेशंस भी लाता है। अगर प्रेगनेंसी रुक गया तो उसमें भी कॉम्प्लिकेशन आ सकता है। लेकिन सबसे बड़ी बात है कि इनफर्टिलिटी का कॉज आजकल पीसीओएस बहुत ज्यादा है, मोस्टली सब डॉक्टर्स के पास है। क्योंकि मैं 90s में जब प्रैक्टिस में मेरे क्लिनिक्स में देखती थी, पीसीओएस कहाँ 4-6 महीना में एक केस आता था, लेकिन आजकल देखो तो एवरी अल्टरनेट डे इज ए केस पीसीओएस का आता ही है। और उसको लाइफस्टाइल मैनेजमेंट बहुत इंपॉर्टेंट है उसके लिए, अलॉन्ग विथ होम्योपैथिक मेडिसिन। कैसे हमको पता चलेगा, डायग्नोसिस कैसे किया जाएगा? रियली रोटरडैम डायग्नोस्टिक क्राइटेरिया बोलता है कि इंटरनेशनल ऑब्स्टेट्रिक्स कॉन्फ्रेंस, गायनोकोलॉजिकल कॉन्फ्रेंस था रोटरडैम नेदरलैंड में। सो उसी कॉन्फ्रेंस में हुआ कि ये डिसीजन हुआ था कि डायग्नोसिस 3 फैक्टर्स उन लोगों ने दिया, उससे अगर 2 फैक्टर्स हम सेटिस्फाई करते हैं, जैसे नंबर 1 इज ऑलिगो एनोवुलेशन, हाइपर एंड्रोजेनिज्म, and hyperandrogenism might be clinical, might be biochemical. बायोकेमिकल हम इन्वेस्टिगेशन किया और उसमें एस्ट्रोजन लेवल ज्यादा आया, तो हम बायोकेमिकली बोल सकते हैं। क्लिनिकली हिर्सुटिज्म है, हिर्सुटिज्म बाल्ड, मेल लाइक बाल्डनेस, मेल लाइक बिहेवियर, और ये सारा आता है, उसमें भी हम डायग्नोसिस कर सकते हैं। नहीं तो बायोकेमिकली मिला तो भी हम कर सकते हैं। और पॉलीसिस्टिक ओवरी अल्ट्रासाउंड में आया तो हम कर सकते हैं। सो 3 क्राइटेरिया से 2 क्राइटेरिया फुलफिल होता है तो हम पीसीओएस बोल सकते हैं। The exact prevalence PCOS is highly variable, ranging from 2.2% to 26% globally. एंड हमारे इंडिया में भी कुछ स्टडी उसके ऊपर है, जैसे साउथ इंडिया में एक है, महाराष्ट्र में एक है। प्रिवेलेंस ऑफ पीसीओएस were reported in South India as 9.13% and in Maharashtra 22.5%. Coming to the case report, हम केस के बारे में अभी डिस्कस करेंगे। सो ये 21-year-old अनमैरिड गर्ल रिपोर्टेड एट अविन चंद्र होम्योपैथी मेडिकल कॉलेज भुवनेश्वर में। मैं जब ओपीडी में थी उस टाइम पे वो आई थी विथ ए क्लिनिकल हिस्ट्री ऑफ डिलेड मेंसेस फॉर लास्ट 3 years ऑन डेटेड 14th April 2011। सो इसी डेट पर वो आई थी। तो 3 साल का उसको डिलेड मेंसेस का हिस्ट्री, डिलेड मेंसेस का हिस्ट्री था और इरेगुलर पीरियड्स था। मोस्टली साइकिल वाज 60 to 70 डेज इंटरवल में होता था और फ्लो 2 to 3 डेज तक होता था, और उसके साथ उसमें पेन लोअर एब्डोमेन भी था। उसका और एक प्रॉब्लम था, अनयूजुअल मिल्क सिक्रेशन फ्रॉम ब्रेस्ट, दोनों साइड से था। क्योंकि वो लड़की थी, वो सिचुएशन उसको बहुत ही एम्बैरेसिंग कर देती थी, तो उसके लिए वो बहुत वरीड हो जाती थी। रिकरेंट हेडेक था, कोई मॉडलिटीज उसने इतना खास करके नहीं बताया। और क्रॉनिक कॉन्स्टिपेशन, डिफिकल्ट सॉफ्ट स्टूल। कुछ मॉडलिटीज उसको मिला था उसमें, हेडेक aggravation by morning after rising up, and anger, thinking long time, exposure to heat, head bath, and ameliorated by mental relaxation. फिजिकल एग्जामिनेशन में वो ओबेस थी, और उनके मुताबिक, उसके बोलने का मुताबिक, वो लास्ट 3 इयर्स में 10 kg वेट गेन किया था। उसका BMI 26.6 था। हमको पता है कि नॉर्मल BMI इज 18 to 24 and 25 to 29 is overweight, obese, and 29 and 30 and above is overweight. So अल्ट्रासोनोग्राफी रिपोर्ट वो जो 28 मार्च 2011 का था, anovulatory cycles with retroverted uterus and a endometriotic mass, उन लोगों ने अल्ट्रासाउंड रिपोर्ट में आया था। ब्लड इन्वेस्टिगेशन में सीरम प्रोलैक्टिन 35.88 था। नॉर्मल आता है कि वो 2 से 29 तक, बट बहुत सारा स्टडी ने बोला है कि यंग एज में इफ दैट इज विद इन 20 दैट्स गुड, बट हियर द प्रोलैक्टिन लेवल वाज 35.88 and the TSH 5.16, higher borderline, because TSH also normal level is 0.5 to 5.5, but in young age, below 20 years of age, yeah, 20, 25, 15, in this age, some studies are there. Somewhere I had read in research articles are there. If it is counted as 3 to 3.5 in case of young girls. Okay. So, but here it was 5.16. So little bit higher borderline we can say on 25th March 2011. So coming to physical generals, patient was hot but susceptible to cold, craving for salt, fried food, non-veg, rich food, bowel constipated, had cracked anus. So no other physical generals were quite normal. So I noticed from the clinical case taking that her psychosocial features, environmental factors were likely to have negative impact on her quality of life and on her ability to self-manage this chronic disease as well as to set lifestyle maintenance goals. This was addressed as priority. So during मैंने जब केस टेकिंग हमारे ओपीडी में हुआ, तब ये मार्क किया गया कि उसका मेंटल सिम्टम्स बहुत इम्पोर्टेंट था। उसका एनवायरमेंटल फैक्टर्स उसके ऊपर बहुत नेगेटिव इम्पैक्ट डाल रहा था। उसका क्वालिटी ऑफ लाइफ उतना खास नहीं था। वो एक जॉइंट फैमिली को बिलोंग कर रही थी, और जो जिसमें आज बीइंग ए गर्ल चाइल्ड होने की तरह उसको उतना इम्पोर्टेंस नहीं दिया जाता। तो और उसके ऊपर साइकोसोशियल फीचर्स भी बहुत ज्यादा था, और इसीलिए वो बहुत ज्यादा उसके लिए अफेक्टेड हो जाती। सो कमिंग टू मेंटल जनरल्स, हमने ये सारा सिम्टम्स उससे कलेक्ट किया था। डिजायर्स टू बी अलोन, रोमांटिक, रिलक्टेंट टू टॉक, always in a grief due to excessive parental pressure, strict disciplined parents, getting tired easily, brought up in a crowded family, physical work pressure was more, likes to enjoy romantic pictures, grief for neglected love from parents due to girl child, being a girl child but unable to express. So उसके मन में कंपैरिजन भी आता था So this is the first investigation report of 28 March 2011, where it is mentioned that normal retroverted uterus, anovulatory ovaries, and adnexal mass with that might be endometriotic mass. What she brought to us. And this serum prolactin was carried out next, that is that came about 35.88, and the thyroid T3 level was 1.23 and T4 8.2, TSH 5.16. Though the normal limit 0.35 to 5.5, but being a girl child of young age, study says that must be within 3.5. So that's why it is little bit higher. So basing upon these symptoms, the reportization sheet, past history was bleeding piles, family history diabetes, hypothyroidism, cancer in maternal site. So after reportization, we have taken total 16 symptoms, and natramur came with the higher rank. Next, which is sepia, then phosphorus. So like this. So I went for natramur 200 once in a week for 3 months along with regular exercise prescribed for the patient. So timeline including follow-up of the case, 24th July 2011. The headache in next follow-up, first follow-up. Headache intensity reduced, frequency reduced, other symptoms as before, and mental stress as before. Investigation reports already we had discussed, and the weight was 68 kg, and medicine, next follow-up medicine, prescribed natramur 1m once in 15 days for 1 month, followed by natramur 10m 1 dose. Again, the patient came to us after 4 months. Headache occasionally, menses regular for 2 cycles, painful cycles, milk secretion as before, and mental stress was as before. Next, again, we went for serum prolactin, which was increased. Previously, it was 35.88, and now it became 44.90. And weight reduction was 2 kg. And in 23rd August 2011. So the serum prolactin level increased. That means our case is not going in a right path, not improving in a right path. Though she had a reduction in a headache, still then the case cure rate is not in the right path. So next we went for intercurrent nodule, that is carcinosin 1m, once in 15 days for 2 months. Next follow-up was in 23rd February 2012. So in that we find the no headache, menses delayed for 40 to 45 days. But in first visit, she had 60 to 70 days. Now she had 40 to 45 days delay. Other symptoms as before and mental stress as before. So weight was same, like previous 66 kg. I went for again natramur 10m 2 doses once in 3 months. So this is serum prolactin 44.90. Next, I went for again in 6th July 2012. The ultrasound of abdomen and pelvis. There the both ovaries are enlarged in length but normal in volume. So they show multiple small cysts, no dominant follicles are seen. But here is in this A ultrasound में endometriotic mass नहीं था. शायद that was due to might be due to natramure that has vanished. So again the same PCOD problem, consistent with PCOD. Next timeline, 15th July 2012. So no headache, no constipation, but menses delayed. Other symptoms as before. Mental stress as before. So ultrasound revealed bilateral PCOD on 6th July 2012. Weight reduction again 2 kg, 64. And medicine prescribed natramure 10 mg 2 doses in 3 months interval. After that, she got married in 2013, discontinued medicine for 1 year and 6 months, avoided conception for 1 year because she has to move like that, and her husband left home for distant job place, and the lady stayed with in-laws to take care of them for last 3 months when she came to us. Again, she approached us in 18th June 2014. Delayed menses relapsed. That means in between she had regular menses to some extent. But again the delayed menses, milk secretion was as before, no mental stress because she was very happy, cheerful, though away from husband for last 3 months. But still then उसके in-laws house में उसका बहुत उसको बहुत love and affection मिला, उसका importance भी था, इसलिए उसको जो स्ट्रेस था वो लेवल बहुत कम हो गया. लेकिन वेट भी गेन कर गई हो, 68 kg था. I went for pulsar. Again I went for a reporterization. Will show you taking these rubrics, that is the chest milk pregnancy, female genitalia, in again the delayed menses, and mind cheerful, weeping disposition. So with this, the pulsatilla, next was a sulfur, like this, next was a lycopodium, sepia, like that. So I went for pulsatilla 1M once in 15 days for 3 months, followed by pulsatilla 10M. Next is, again the lady didn't come to me. Again she approached me in 2016, 5th January 2016. At that time she was staying with her husband and in-laws for last 13 months, but no conception. 13 months हो गया वो रहती थी उसके साथ, but conception नहीं हुआ. Again menses delayed for 5 to 7 days only. Scanty flow for 2 days, acrid, offensive leukorrhea, aggravation after menses, and milk secretion relapsed occasionally. No conception. So in this case, the case was again reviewed. So repeated cold attack was there, mental symptoms recognized, indicating indifferent to everything, even to sex, due to tiredness, has no desire for any work, but does forcibly. Good moral character she had, sensitiveness, no emotional attachment, she was very responsible, weak and tired feeling. So the case, the mental symptoms were reviewed because with the pulsatilla, she, after natramure, she had the milk secretion was as usual, the stress level was as usual, only the menses interval reduced to some extent and headache reduced. After that, again carcinosin, again I went for case was reviewed, and I went for pulsatilla in 2014. After pulsatilla, the menses interval reduced 5 to 7 days, but still 14 to 16, She continued to be with her husband for 13 months. She had already taken pulsatilla 10 mg, but she didn't conceive, and the milk secretion also relapsed occasionally. Okay. And had acquired offensive leukorrhea aggravation after menses. And the mental symptoms reviewed. In this case, still I remember the mental symptoms helped me a lot. If हम जब पढ़ेंगे कि कैथरीन कुल्टर में सिपिया इज अ ड्रग एंड वेरी वेल डिफाइंड, बहुत सुंदर से उन्होंने लिखा है कि इनफर्टिलिटी के लिए नाट्राम्यूर, कैलकेरिया कार्ब, सिपिया आर वेरी गुड ड्रग्स। एंड और भी बोले हैं कि सेपिया में हम 3 तरह का, वो दैट इज ए फीमेल रेमेडी, एंड हम 3 तरह का फीमेल हमको मिलते हैं, फीमेल कैरेक्टर्स हमको मिलते हैं सेपिया में। नंबर 1 इज ओवरवर्क्ड, मैंने लिखा ओवरवर्क्ड हाउसवाइफ और इमोशनली विड्रॉन हाउसवाइफ, overworked wretched housewives. Catherine Coulter has written the word overworked wretched housewives. That is वो लड़की का शादी हो गया, उसके बाद उसके हस्बैंड बाहर गए और वो इन-लॉज के साथ रहती थी, बहुत खुश थी, लेकिन वो उसको भी प्यार मिलता था, वो उसको वो चाहिए था, सब ठीक था, लेकिन उसका वर्क प्रेशर इतना ज्यादा हो गया उस फैमिली में कि धीरे धीरे उसको डिसअपॉइंटमेंट आया। सो ओवरवर्क्ड रेचेड हाउसवाइफ्स, उसको डिसअपॉइंटमेंट आया और धीरे धीरे इतना डिसअपॉइंटमेंट आया कि वो सबसे बात करने को उसको मन नहीं आया, और उसको काम का प्रेशर इतना था कि उसके हस्बैंड के साथ भी वो रोमांटिक बात, और जो बहुत रोमांटिक थी, लेकिन वो कैरेक्टर उसका धीरे धीरे चेंज हुआ और वो उतना उसमें इंटरेस्ट ही नहीं रहा, उस स्पेसिफिकली सेक्स में भी उसको इंटरेस्ट धीरे धीरे नहीं आया, क्योंकि वो बहुत टायर्ड हो जाती, उसको मन में नहीं था, ये बात नहीं था, उसको लव एंड अफेक्शन दूसरों के लिए नहीं था, ये बात भी नहीं था, क्योंकि वो बहुत टायर्ड हो गई थी, उसका मैनिफेस्टेशन उसको नहीं आता था। तो अब जब मैट्रामेडिका में हम जाएंगे, रियली मैट्रामेडिका भी यही लिखता है कि सिपिया द लव एंड अफेक्शन इज देयर बट इट इज बिनॉम्ड, द मैनिफेस्टेशन इज बिनॉम्ड, मैनिफेस्टेशन हो नहीं सकता क्योंकि वो बहुत टायर्ड हो जाती थी। एक तरह का, दूसरी तरह का हमको मिलता है सिपिया लेडी, कि हम थोड़ा मैट्रामेडिका डिस्कस करें यहाँ पे, तो उसको मिलता है कि हमको एक तरह का मिलता है ओवरवर्क्ड रिचेड हाउसवाइफ्स और इमोशनली विड्रॉन वुमेन। सेकेंड कैटेगरी हमको मिलता है कि कैरियर ओरिएंटेड, कैरियर कंटेंटेड वुमेन, कैरियर कंटेंटेड वुमेन, वो कैरियर में उतना घुस जाते हैं कि और सारी तरफ से उनको अच्छा नहीं लगता, वो उनको विड्रॉ करने की सोचते हैं, इवन इफ फैमिली मेंबर से, सब काम से, और उनका जो सेक्सुअल लाइफ है उससे, सबसे वो चाहते हैं कि उस टाइम अगर कैरियर के लिए दिया जाए तो अच्छा है, इसमें क्यों देने का। तो इसीलिए वो धीरे धीरे उससे भी विड्रॉन हो जाते हैं, इंडिफरेंट हो जाते हैं। दैट हैपेंस इन सेपियालिटी। एंड द थर्ड कैटेगरी इज डिससैटिस्फाइड कंप्लेनर, वो किसी में भी सेटिस्फाइड नहीं होते, ट्यूबरकुलिनम की तरह। सो उसमें थोड़ा सा ट्यूबरकुलर फीचर्स थोड़ा बहुत उसमें आता है ये सब, जो साइकोटिक मैजम का है, सर तो बहुत ज्यादा बोलेंगे मेरे से, साहनी सर है यहाँ पे। सो लेकिन उसमें थोड़ा बहुत वो सिप्लिटिक फीचर, सुडो ट्यूबरकुलर फीचर्स भी है, जिसके लिए वो थोड़ा डिससेटिस्फाइड हो जाती है, और उसके लिए भी वो सबसे विड्रॉन होती है। तो ये विड्रॉन इंडिफरेंस कैरेक्टर उसमें बहुत ज्यादा मिलती है सिपिया में, जो हमको नाट्राम्यूर में भी मिलता है, फॉस्फोरस में भी इंडिफरेंस मिलता है, लेकिन नाट्राम्यूर में प्लीजेंट थिंग्स के लिए, प्लेजरेबल थिंग्स के लिए, एंजॉयमेंट के लिए इंडिफरेंस मिलता है, और फैमिली मेंबर्स के लिए नहीं। फॉस्फोरस में, फॉस्फोरस तो प्राइमरीली वो इंडिफरेंट नहीं है, बहुत एंजॉय करती है फैमिली लाइफ, बहुत एंजॉय करती है फ्रेंडशिप और रोमांटिक और घूमना, पिक्चर देखना, सारा एंजॉय करती है। लेकिन बाद में सेकेंड जब सो रहा होती है सेकेंडरीली, वो कुछ साल के बाद जब सबसे उसको कुछ डिप्रेशन आता है, कुछ बिट्रेडनेस मिलता है, तो ग्रेजुअली सोरिक फॉस्फोरस गोज टू द ट्यूबरकुलर और सिप्लिटिक वन। सो उस फेज में जब सेकेंडरी फेज फॉस्फोरस का आता है, जिसमें वो सोरा से ट्यूबरकुलर की तरफ जाता है मैजम, तो उसी फेज में पैथोलॉजिकली भी वो बहुत ज्यादा सोरिक फीचर से ट्यूबरकुलर फीचर मैनिफेस्ट करती है फिजिकल स्फीयर में। मेंटल स्फीयर में भी जो इतना एंजॉयमेंट उसको था, रोमांटिक था, फैमिली एंजॉय करता था, फ्रेंड्स एंजॉय करता था, वो इंडिफरेंट हो जाता है। दैट इज इन सेकेंडरी फेज, इन ट्यूबरकुलर फेज, नॉट इन प्राइमरी फेज ऑफ फॉस्फोरस। सो फॉस्फोरस का दो फेज होता है इंडिफरेंस, जब वो सेकेंडरी फेज में आता है, जो जब वो किसी से बातें भी करना नहीं चाहता, बातें सुनना भी नहीं चाहता। लेकिन सेपिया में ऐसा है नहीं। सेपिया एवरी फेज, अगर प्राइमरी हो सेकेंडरी हो, और फैमिली मेंबर्स हो या प्लेजरेबल इवेंट्स हो, किसी के लिए भी उसका अटैचमेंट नहीं रहता है, वो विड्रॉ करती है और इंडिफरेंट हो जाता है। सो इंडिफरेंट में हमको रिपोर्टरी में सीपिया इसीलिए हायर ग्रेड में मिलता है। सो लेकिन सीपिया का क्या है कि वो इसी केस में क्या हुआ, वो अगर चाहती तो उसके हस्बैंड के साथ पहले से भी जा सकती थी, वो उसके इनलॉज के पास नहीं रहती, वो झगड़ा करती कि नहीं मेरे को जाना है। लेकिन उसने ऐसा नहीं किया, उन्होंने इनलॉज के साथ रुका, क्योंकि उसको ड्यूटी कॉन्शियसनेस है, उसका मोरल सेंसिटिविटी है, वो सीपिया ड्यूटी कॉन्शियस है। उसको लगा कि मेरा ये ड्यूटी है कि मैं मेरे इनलॉज का ख्याल रखूं, वो उसके अंदर है। फिर भी वो इतना काम का प्रेशर उससे हुआ कि वो सबसे विड्रॉ हो गई। उस कई धीरे धीरे ये सिम्टम्स उसमें आ गया, जो अंदर था कॉन्स्टिट्यूशन वैसा था, लेकिन वो मैनिफेस्टेशन नहीं हो सका था, वो हो गया। सन इन्वेस्टिगेशन रिपोर्ट्स के लिए हमने भेजा। सो टीएसएच अगेन बढ़ के आया, 5.16 से 6.32 आया। प्रोलैक्टिन, क्योंकि उसका मेंटल स्ट्रेस लेवल और भी बढ़ गया था, तो उसमें टीएसएच लेवल बढ़ता है। ओके, प्रोलैक्टिन, लेकिन प्रोलैक्टिन कम हुआ 28.99। पहले जो 35 पॉइंट समथिंग था, फिर 44.9 था, फिर इस बार वो रिड्यूस होके 28.99 हुआ। टीएसएच 6.32 था और हीमोग्लोबिन 11.6 था, डेटेड टू 2 जनवरी 2016। वेट भी थोड़ा रिड्यूस हुआ था एंड मेडिसिन उस टाइम सीपिया प्रेस्क्रिप्शन किया गया, क्योंकि पहला प्रेस्क्रिप्शन आपने देखा होगा उसमें नाट्राम्यूर के बाद सीपिया आया था, और नाट्राम्यूर का कॉम्प्लीमेंट्री भी सीपिया था, बीच में पल्साटिला आया। पल्साटिला का फॉलो प्रीमेडी भी सीपिया बहुत अच्छा होता है। सो इसी हिसाब से सीपिया 200 once in a week दिया गया, एंड दिस इज द रिपोर्ट। क्या यू कैन मार्क टीएसएच इसमें 6.18 है, और प्रोलैक्टिन का शायद इसमें नहीं है, शायद इसमें नहीं है, लेकिन उतना था। ओके, सो अगेन फिर वो था 5th January 2016. Next she came to me in June, 16th June 2016. No conception for last 1.5 years, no milk secretion for last 4 months, indifferent to everything, even to sex, too much tired after overexertion for last 1.5 years, no emotion for anybody, menses irregular. Again irregular menses. So TSH इसमें सीपिया में देखिए टीएसएच कम हुआ, 3.75 हुआ, प्रोलैक्टिन और भी कम हुआ, 11.68 हुआ on 18th June 2016, and weight again reduced 58 kg, but no conception. So in that case, a strong psychotic drug, psychotic mass antipsychotic drug I have chosen. For indifference is there, infertility is also there, and the pathology of ovarian cyst is also there. So Medrinum 1M was chosen. 2 doses, once in 15 days interval, again followed by Sepia 1M. Sepia 1M followed by Sepia 10M with frequent outings for mental relaxation. So this is very very important, lifestyle management. So उसके हस्बैंड को मैंने तब एडवाइस किया था, वो कलकत्ता में रहती थी तब. सो फ्रीक्वेंट आउटिंग्स के लिए बोला था. सो वो लेके गया. नेक्स्ट शी केम टू मी इन 15th June 2017. So at that time she had pregnancy of 20 weeks. So and the TSH again, I due to inquisitiveness I send her for routine tests of pregnancy. I have seen, and TSH at that time 16th March 2017 she had done 4.92 was there, and CPR 10M was diluted doses once in a week लेने के लिए मैंने दिया, along with iron, calcium and a proper diet of pregnancy. She continued. Because why I continued like this? Because from last 35 years, mostly we can say 30 years of my practice, 35 years practice, for on pregnancy I am working for 35 years. But like this, during pregnancy, to go for a constitutional remedy, I am working since last 2001. So for last 23 years, you can say. So within this, what I have marked near about, in these 23 years, near about 2500 से ज़्यादा या 3000 के अंदर ही मैंने प्रेगनेंसी केसेस देखा है. और इसमें एंटीनेटल चेकअप हमारे क्लिनिक्स में हम करते हैं, और इन्वेस्टिगेशंस भी हमारा क्लिनिक्स में हम पैथोलॉजी वालों को बुला के करते हैं, और अल्ट्रासोनोग्राफी के लिए हम भेजते हैं, और सारा एंटीनेटल चेकअप मैं करती हूँ. लास्टली डिलीवरी के लिए जब लेबर प्रोग्रेस होता है तो हम कोई गायनेकोलॉजिस्ट से बात करके उनको केस को भेजते हैं, या पेशेंट का नियर बाय हॉस्पिटल से वो करती है. तो ऐसा हमारा यूजुअल प्रैक्टिस है. तो मेरा, तो उसमें आई हैव मार्क दैट हम अगर ड्यूरिंग प्रेगनेंसी हम कॉन्स्टिट्यूशनल रेमेडी बेसिंग अपन दी प्रेजेंटिंग कंप्लेंट, फिजिकल जनरल्स, मेंटल जनरल्स अगर हम प्रेस्क्राइब करते हैं, तो उसमें मोस्टली बच्चा तो बहुत इंटेलेक्चुअली भी हेल्दी होता है, मेंटली हेल्दी होता है, फिजिकली भी रिलेटिवली हेल्दी होता है. सो और आज तक आई हैव नेवर नॉट सीन इवन ए सिंगल केस ऑफ ऑटिज्म एंड ADHD. जितना भी प्रेगनेंसी हमारे कॉन्स्टिट्यूशनल रेमेडी में हमने देखे हैं, उसका आउटकम बच्चे तो अभी 10 साल 15 साल 20 साल का भी हो गए हैं. सो लेकिन उसमें कोई ऑटिज्म ADHD आज तक हमने, या माल कॉन्जेनिटल एनोमली अभी तक नहीं देखे है. सो ये भी, वो भी हमारे माइंड सेट हो जाता है कि ये कॉन्स्टिट्यूशनल रेमेडी आप कंटिन्यू करो थ्रू आउट प्रेगनेंसी. अलॉन्ग विथ आयरन लेना है, कैल्शियम लेना है, टिटानस टॉक्साइड भी लेना है, इंजेक्शन लेना लगाना है, और प्रोटीन भी लेना है. और जब कुछ कंप्लेन आता है तो उसी हिसाब से कोई ड्रग, जो भी फीवर हुआ, बुखार हुआ, लूज मोशन हुआ, या खांसी हुआ, या कुछ भी हुआ, उसके लिए एक्यूट रेमेडी जो आता है वही उसके साथ तुम कंटिन्यू करो. ये हमारा एडवाइस हर पेशेंट, हर प्रेगनेंसी केस के लिए रहता है. सो उसी हिसाब से वो कंटिन्यू किया. दिस इज द रिपोर्ट. TSH 3.78 एंड प्रोलैक्टिन 11.7. अगेन दिस इज ग्रुप ए पॉजिटिव. वो सारा प्रेगनेंसी का रिपोर्ट्स था. 11.8 था हीमोग्लोबिन, एंड ये हुआ उसका अल्ट्रासाउंड रिपोर्ट, ये दिखता नहीं शायद, बड़ा करने से पता चलेगा। हाँ, इसमें इसमें प्रेगनेंसी का नहीं, ये बीटा एचसीजी का रिपोर्ट है जो प्रेगनेंसी पॉजिटिव दिया था 1933 था, 1933 बीटा एचसीजी का रिपोर्ट है ये, तो जो इंडिकेट करता है कि प्रेगनेंसी पॉजिटिव है। फिर बाद में सिंगल वायबल फीटस ऑफ अराउंड 12 वीक्स 6 डेज मैच्योरिटी, नेक्स्ट अल्ट्रासाउंड रिपोर्ट था ये रिपोर्ट हमने आईजीएम टॉक्सोप्लाज्मा का उसी टाइम पे किया था, तो ये भी नॉर्मल आया था। नेक्स्ट अल्ट्रासोनोग्राफी was single life fetus of 20 weeks and 3 days। वो ये रिपोर्ट को उसके जहाँ रहती थी वहीं पे कराती थी और भेजती थी हमको। रिपोर्ट्स हुई थे वो पास में, वो गायनेकोलॉजिस्ट से किया, कितने बार चेकअप किया और हमारे पास जब आया तो हमारे पास ही चेकअप। So 8th February 2019 she delivered a male baby, normal vaginal delivery। No, she came to me on normal vaginal delivery on 30th October 2017। बेबी को लेके वो February 2019 में हमारे पास आया। Okay, no complaints in last 2 years, menses were regular, flow normal, no headache, no constipation। इन्वेस्टिगेशन हम जानने के लिए उसको भेजा कि वो 8 फरवरी 2019 में प्रोलैक्टिन का लेवल क्या हुआ, वो आया 4.38, टेस्टोस्टेरोन वाज 12.98 एंड इंसुलिन वाज 0.50। टीएसएच लेकिन उस टाइम टीएसएच उसको 10.35 था। एडवाइज्ड फॉर लाइफस्टाइल मॉडिफिकेशन along with same CPR 10N। सो लाइफस्टाइल मॉडिफिकेशन नहीं हो सका इसीलिए टीएसएच लेवल बढ़ा। सो उसको हमने फिर एडवाइस किया कि तुम लाइफस्टाइल मॉडिफिकेशन करो और उसके साथ फिर CPR 10M दो। सो ये हुआ ये सारा रिपोर्ट्स जो बाद में हमने किया। डिस्कशन में मेन स्टेप है कि लाइफस्टाइल मॉडिफिकेशन में योगा, एक्सरसाइज, मेडिटेशन, अप्लाइंग थ्रू मेंटल रिलैक्सेशन। बच्चों को हम मेडिटेशन स्ट्रिक्टली एडवाइस करें तो पेशेंट सुनना बहुत मुश्किल है, उसको कैसे करना है, उसको थोड़ा अगर वो एक्सरसाइज योगा आसन नहीं करते हैं तो वो आजकल क्या होता है कि वो जो डांस क्लास जाते हैं कि वो जिम जाते हैं कि वो और कुछ कुछ करते हैं, उसमें भी उनका वेट रिडक्शन बहुत अच्छे से होता है और वो भी उसमें भी उनका मेंटल रिलैक्सेशन होता है, तो वो स्ट्रिक्ट मेडिटेशन नहीं करने पर भी चलेगा, वो उसमें इतना प्रॉब्लम नहीं होगा। सो दिस इज द एनालिसिस, ऐसा था, हमने ऐसा कंटिन्यू किया। profound grief, discontented, profound grief seizes, ग्रीफ मेंसेस को सीज कर देती है, इग्नेसिया नाट्राम्यूर सेपिया, और डिस्कंटेंटेड प्राउडी, ये सब भी था उसमें, सेपिया था। लेकिन इंडिफरेंस, अवर्सन टू सेक्स भी था, बट ये सारा सिम्टम्स इंडिफरेंस आता है, फॉस्फोरस कैल्केरिया पल्साटिला में भी आता है इंडिफरेंस, लेकिन वो प्राउडी, डिस्कंटेंटेड वो सब नहीं होते हैं, वो रिवर्स है। मैनिफेस्टेशन ऑफ लव की हम बात करें तो फॉस्फोरस एंड पल्साटिला हम देखें तो इजीली उनके लिए इजीली पोर आउट अफेक्शन एंड केयर। नाट्राम्यूर प्रोवाइड्स इंस्ट्रक्शन इंस्टिंक्टिवली अज्यूमिंग द रोल ऑफ ए टीचर, टीचर जैसे करते हैं रोल, वो वैसा ही लव करता है, तो बहुत केयरिंग है। फॉस्फोरस पल्सेटिला बहुत ही अफेक्शनेट है, लेकिन उनका मैनिफेस्टेशन वो पोर आउट पूरा उसके ऊपर डालते हैं। और कैलकेरिया इंडल्जेस हर चिल्ड्रन एंड एंजॉयज देम इन एन इफर्टलेस एम्पैथी, वो अपने चिल्ड्रन के लिए बहुत सारा लव है उसका कैलकेरिया का, दूसरों के लिए थोड़ा कम। आर्सेनिक, आर्सेनिक भी लव बहुत करता है, लेकिन उसका वॉइस कमांडिंग होता है, लव करता है लेकिन कमांडिंग वॉइस उसको होता है। सेपिया, लव उसमें एब्सेंट नहीं, वो बिनम्ड है और वो एक्सप्रेस नहीं कर सकता, इतना ड्यूटीफुल और डिसकंटेंटेड है कि ड्यूटीफुल है लेकिन डिसकंटेंटेड है साइमल्टेनियस। एंड लव उसको एक बर्डन लगता है, उसको प्यार करना एक बर्डन रिस्पॉन्सिबिलिटी लगता है, बर्डन लगता है। लाइकोपोडियम, वो फॉरसेक्स उसके फैमिली को बहुत नेग्लेक्ट करता है, लेकिन उसके लिए उसको कोई गिल्ट भी नहीं आता कि वो कंडेम भी नहीं, सेल्फ रिग्रेट भी उससे नहीं होता है। सर मैं लव का मैनिफेस्टेशन हमारे मैट्रिया में बहुत सुंदर से डिफरेंट ड्रग में डिफरेंट टाइप ऑफ मैनिफेस्टेशन हमको मिलता है। So this is my mental relaxation is like this. This is a square you can take, good sleep and exercise, yogashan like that, yeah, aerobics, dance, yeah, pure meditation. All these things are very good. Should be done in PCOS. Should be done. And along with homeopathic medicine. अगर ये सब नहीं होता है, ओनली होम्योपैथिक मेडिसिन में इम्प्रूवमेंट है, लेकिन बहुत परसेंटेज बहुत कम है। अगर ये दोनों ऐड हो जाते हैं तो क्योर रेट बहुत अच्छा है, बहुत ही अच्छा है, हम वेल मैनेज कर सकते हैं। पीसीओएस इज ए डिजीज, वो मेनोपॉज में ही 100% क्योर होता है, हम उसको मैनेज करना चाहिए, अच्छे से मैनेज हो गया तो इनफर्टिलिटी फर्टिलिटी में कन्वर्ट हो जाता है, वही हमारा एम है। सो हम उसको ही अच्छे से मैनेज करना चाहिए। दैट इज द माय मैसेज इज होम्योपैथी कॉन्स्टिट्यूशनल रेमेडी along with all these 4 things. So thank you everyone. So these are the references I have taken. So this is the written consent from the patient. So thank you everyone. Any question?
क्वेश्चन कोई बताने वाले नहीं है। चलिए, बहुत अच्छा प्रेजेंटेशन हुआ मैडम पांडा जी,
Thank you.
बहुत बढ़िया पीसीओएस का केस था और बहुत बढ़िया से होलिस्टिक और जो है इस तरह का जो है कॉन्स्टिट्यूशनल ट्रीटमेंट दिए, इंटरकरेंट मेडिसिन भी दिए, कार्सिनोजेनिक, बहुत अच्छा है। मैं धन्यवाद देता हूं और आप जो है बधाई भी देता हूं कि साथ साथ कि आप गवर्नमेंट सेक्टर से रिटायर कर गए, अब फ्री हो गए, अब होम्योपैथिक को आप ज्यादा से ज्यादा हम लोग के बीच लाएंगे, है ना।
Thank
आइए,
you.
दोबारा भी आइए, मैं जो है बधाई
पक्का
देता हूँ।
पक्का
थैंक यू, थैंक यू।
पक्का। जब आप लोगों की एनकरेजमेंट मेरे को मिला ना, इंस्पिरेशन मिला आपसे।
चलिए, हाँ,
थैंक
हम
यू
बिहार
थैंक
से हैं, बिहार में सुपौल जिला है,
यू।
सुपौल जिला से है। हम
हाँ
डॉक्टर आरपी शाह, सुपौल जिला से। चलिए, बहुत अच्छा लगा आपका जो है, 2-3 बार से आपका शेयर जो है गड़बड़ा रहा था, ये हम सब सुनते हैं, लेकिन आज बहुत फुल्ली हुआ है, बहुत बढ़िया से हुआ है आपका शेयर। चलिए, ठीक, बहुत बहुत धन्यवाद।
थैंक यू धन्यवाद, आपसे प्रेरणा मिला ना।
हाँ, हाँ। आज दीपमाला गायब है भाई, आपका दीपमाला भी गायब है, साथ में आपके गुरुजी डॉक्टर एम के साहनी जी, वो भी गायब हैं लगते हैं, आज कोई है ही नहीं। कोई है ही नहीं, इसीलिए हमको फ्री से मौका मिला बोलने का।
नहीं
इसके
नहीं,
लिए भी
डॉक्टर
हम
दीपमाला थे लास्ट तक, तो डॉक्टर दीपमाला थे,
अभी
मैंने
अभी
देखा।
गायब है, आपका सानी जी भी नहीं है, दीपमाला भी नहीं।
ओके।
और हाँ हाँ, तो हम सोचे कि देखे कि जो है अनम्यूट हो जा रहा है, तो हम भाई बता दिए आपको, धन्यवाद इसके लिए। ठीक, बहुत अच्छा, बहुत अच्छा।
थैंक यू, थैंक यू।
हम्म,
तो हम अभी लीव करें, हम छोड़े, या और
हाँ,
किसी का कोई क्वेश्चन है?
अब जब तक आपका जो है होस्ट या को होस्ट नहीं बोलते
और
हैं
3 मिनट, और 3 मिनट है मेरा टाइम, और
हाँ
3 मिनट है।
हाँ, तो
3 मिनट
को
है।
जब तक, हाँ 3 मिनट है, बहुत बढ़िया दिए। ऐसे ट्रीटमेंट के लिए मैथमेटिक ट्रीटमेंट इज द बेस्ट ट्रीटमेंट। मेन कॉज ऑफ डिजीज अकॉर्डिंग टू लॉ ऑफ होम्योपैथिक साइंस, म्याज, सोरा, साइकोटिक एंड सिफिलिटिक, है ना। सोरा इज द नेसेसरी, है ना। सोरा
हाँ,
जो है सभी आदमी में, और सोरा तो है ही, बिना सोरा का कोई पैदा ही नहीं हुआ है।
एग्जैक्टली।
सोरा तो कॉम्बिनेशन,
तो
है
पक्का
ना।
ही है,
हाँ,
लेकिन
सोरा सब में
लेकिन
रहता।
पैदा
हाँ,
होने का टाइम वो सोरा हो सकता है, या साइकोसिस या सिफिलिस भी हो सकता है।
नहीं वो
पैदा
तो
होने का टाइम,
मिक्स मिक्स हो सकता है। सोरा जो है, सोरा का बिना तो हम पैदा ही नहीं हो सकते हैं। सोरा तो
हाँ वो तो
है ही,
सही बात है।
है
नहीं, वो
नहीं।
तो सही बात है, लेकिन
हाँ
डोमिनेंट में जब सोरा होगा,
हाँ
ऐसी
हाँ
बात
हाँ
नहीं,
हाँ,
ऐसा नहीं।
सोरा साइकोटिक सिप्लिटिक मिक्स म्याज होगा, समझे
हाँ,
ना। हाँ,
सॉरी मैम,
मिक्स
मैं
म्याज।
डिस्कनेक्ट हो
हाँ
गई थी। हमारे
ठीक,
हमारे सब क्वेश्चंस भी आए थे चैट बॉक्स में। मैं
हाँ
डिस्कनेक्ट हो गई तो मैं क्वेश्चंस नहीं देख पा
चलिए।
रही हूँ। मैम
हाँ,
चैट बॉक्स
चलिए
ओपन
आई,
करके क्वेश्चंस का
चलिए
आंसर
ठीक है,
दीजिए।
दीपमाला आ गई है, दीपमाला आ गई है। अब अपना क्वेश्चन,
यस यस, मैं क्वेश्चन बोल नहीं पाऊंगी ना, क्योंकि अब वो मैं डिस्कनेक्टेड हो गई थी। मैम आप चैट बॉक्स खोल ले, क्वेश्चंस हमारे पास है 3-4।
एलेम्पोटेंसी।
यस।
हाँ, डॉक्टर हरिनारायण प्रसाद ने बोले हैं कि रिगार्डिंग एलेम्पोटेंसी, रियली एलेम्पोटेंसी इज टू गुड। सर आई एग्रीड विथ यू, क्योंकि एलेम्पोटेंसी मेरा बहुत ज्यादा प्रैक्टिस है, एंड वो बहुत अच्छा है। लेकिन फर्स्ट इसी केस में क्या हुआ कि स्पेसिफिकली इन केस ऑफ इनफर्टिलिटी, व्हाट इज माय एक्सपीरियंस, सेंटेसिमल, आई गॉट गुड रिजल्ट्स विथ सेंटेसिमल, but in most of the cases LM potency is always good, always good.
हमारे पास और भी क्वेश्चंस है मैम, 3-4
Yes,
क्वेश्चंस
yes,
है।
I am saying, madam,
यस यस।
rubella IgG positive and miscarriage. Yes, sir, I had very good cases. If next time the host will give me the chance, then I will go for your answer in a session about rubella IgG positive. I will present 2 cases of rubella in that session. Okay, how that continued? Two, no, more than 2 cases, near about 4-5 cases I will present about torch. Either might be rubella, might be toxoplasma, might be herpes
सॉरी टू
simplex.
इंटरप्ट यू मैम, माय आवर टाइम इज ओवर। हमारा टाइम खत्म हो गया। अब हमारा नेक्स्ट सेशन का टाइम
Okay,
इंग्लिश
okay,
सेशन का
madam.
टाइम।
So on this, my request is you may, if you will give me a chance, I will present torch infections.
यस यस, नेक्स्ट टाइम। नेक्स्ट
Okay,
टाइम सर
okay,
से बात करके आपको फिर से टाइम शेड्यूल बता दिया जाएगा मैम। नाउ
yes,
सर, थैंक यू वेरी मच मैम।
Yes.
okay.
हमारा
Thank you,
हिंदी सेशन खत्म हो रहा है और इंग्लिश सेशन स्टार्ट हो रहा है।
thank you. Namaste.
मंच में डॉक्टर मनोज का हैंड ओवर करिए। ओवर टू यू सर।
Hello
Namaste.
everybody,
Namaste.
this is IFPH English edition. I am Dr. Manoj. Welcome you all to the 1280th day of continuous and uninterrupted Zoom session of IFPH. Let us start today's program with a silent prayer for 1 minute. Welcome back. Today our guest is Dr. SAPTARSHI CHOUDHARY MD, Professor, Head of Department, Practice of Medicine and Visiting Professor Mahesh Bhattacharya, Homeopathy Medical College and Hospital, Howrah, West Bengal. A lot of discussions are there. I'm not going to all these things, but the publication we must pay attention. That is Chaudhary S and Kudabaksh are deep vein thrombosis cured by homeopathy. Then Mukesh K.S. Ganguly and Chaudhary, homeopathic medicine used as prophylaxis in Calcutta during COVID-19 pandemic. Then another one is homeopathic management of pain and stiffness of arthritic knee joint, clinical data analysis of palliation criteria and observational study. Then another one is traumatic tongue fibroma treated with individualized homeopathic medicine, a case report with brief literature. Then another one is what with burning pain and occasional bleeding treated with individualized homeopathy. A lot of publications are also there, and the subject is approach to cases of anxiety disorder through homeopathy. We all know that this is an era of anxiety disorder. Anxiety is everybody is buried in anxiety. So it's an important topic. On behalf of IFPH, I welcome Dr. SAPTARSHI. You can have the platform for the next 45 minutes. It's over to you. Please proceed.
Thank you, sir. Thank you very much. Let me share my screen.
Yes, okay, you can share.
Need to make it a, this should be just a minute. How to make it a whole screen? Actually, if I can, yeah, if I can make it a pause share, just a minute.
You can just click on the side screen so you can have this, go through the different slides.
Yes, that is the thing. I'm not been able to do that thing.
Maybe some technical problems are there.
Yeah, maybe.
And no need of anxiety. Take your own time, no problem.
Just a minute, sir. I am not able to do that thing. Okay, whatever.
You can proceed without screen, even without screen share, you can go.
No, I can share my screen, but the thing is that actually I need to make it, the whole screen should be shared. I mean, what I can share now is resume share. Yes, I think.
Or you can re-enter on start.
Yeah, that I can do.
No problem. First, you please close your screen sharing and then I can start again. Then it may be right.
Yes, sir. Something is actually happening. Let me see if I can.
Where you please close the screen sharing and once again, then you can restart, sir, and it may be better.
Pause share. Yes, I have done it. And now desktop. I don't know, something is actually not working somehow. Whatever. Can you see?
Yes, yes.
Okay. So without wasting much more time, let us go to the thing. As you have already said, sir, it's really true that the era we are right now living in is basically era of this stress and anxiety disorder. And most of the cases we are dealing in our OPD and IPD. Basically, obviously, as we know, our homeopathic hospitals have a very good OPD setting and obviously IPD setting. But the people, those who are coming to us, if we carefully observe them and if we carefully go through the anamnesis, we can easily understand that most of the people coming with some sort of manifestation of anxiety disorder. Now, the thing is that as a homeopath, we have an entirely different set of view to the patients, those who are having, to the disease condition, because we do not treat disease condition, rather we treat the person, those who are suffering from disease, that is the sick individuality. the thing that we have to always remember while we are going to treat the patient, because naming the disease, it's okay for, I mean, classification of the disease to be at par with the modern era, modern diagnostics, and to be at par with the other systems of medicine. We have to do that thing, but it doesn't mean that we have to walk in their own way, I mean their way. We have to have we have a very good way of our own, and we have to stick to that thing. Now, what is it's a part of psychiatric disorder, so that's why I'll first like to say that what is psychiatric disorder. Psychiatric disorders are such clinical condition which are characterized by some problem where there is where is the problem in the motivation. If there is a disorder of motivation, disorder of emotion, then disorder of cognition, and obviously socialization. Now, initially, since this anxiety disorder is a part of this psychiatric disorder, now with time, actually, the modern medicine, what they do, they usually change, and they usually, you know, change their classification of their mental diseases as per, obviously, they classify through their ICD-10. Right now, there is ICD-11, and there is DSM-5. And the present classification of mental disorder through DSM-5 is like that. And obviously, we know this classification changes from time to time. But for our own practice, our own clinical practice, what we can do, we can simplify this kind of mental disorder. I mean, obviously, not according to the Hahnemannian way, but for the sake of diagnosis, we can at least simplify that thing into like this: anxiety disorder, mood disorder, disorders of childhood and adolescent, somatic symptom disorder, feeding and eating disorder, personality disorder, schizophrenia, and mental health problem. But among all these things, I have very purposefully written that anxiety disorder on the top, because most of the patient, as I have already told, those who are coming to us are suffering from some manifestations of this kind of anxiety disorder. And obviously, mood disorder and other disorder, these are also there, but perhaps the most prominent features that we are getting is anxiety disorder. So what is basically anxiety disorder? See, some sort of anxiety is obviously better for sincere performance. Right now, obviously, I'm also having some sort of anxiety because I'm going to present before a learned audience. So that's why there was some sort of a bit anxiety is there, and it is required. I mean, because having that kind of anxiety, obviously, you will have some, you know, that will be a driving force. But when this anxiety is actually, with the anxiety, the ease of life is lost, then that condition is a disorder then. So if there is a persistent or excessive, uncontrollable, and unrealistic worry, which is like apprehensive expectations, as we can say, about a number of events or activities of life, if such thing actually happens, then we can say that the person is suffering from a disordered condition because of anxiety. So this persistent, excessive, uncontrollable, and unrealistic worry is a key factor. Now, if we look at the present scenario in our country, the depression and anxiety disorder, they are cropping up like anything. I mean, perhaps they're increasing in each and every day. And most of the people, and you know, even the youth, even the children, they are a large number of population, they are suffering from this anxiety disorder. If we look at the anxiety disorder prevalence by age, right now it's in 2019 data. If we see the age prevalence of anxiety disorder, we can easily find out that people, those who are in the even early, you can see the early adult. Can you see my screen, sir?
Yes. I think slide number 8. Yes.
Yeah, can you see?
Yeah, right.
Oh, okay. What I was talking about, the pre-COVID and post-COVID era, it has the entire thing has been changed. I mean, even we can see the anxiety disorder is prevalent, is much more. I mean, the COVID scenario has entirely changed the world. I mean, world, and the anxiety is perhaps the most prominent symptomatology, or the most prominent thing which we have observed during the period of COVID, and the social distancing, and I mean, you know, the panic of a disease condition, and all these things actually a huge number of population, they actually suffered from anxiety disorder pre and during the time of COVID, and obviously post COVID scenario. Now, why this kind of anxiety disorder is there? There are so many theorems and so many so many analytical pathway we can say. We can say that the brain amygdala appears the key modulating factor for the fear and anxiety, and obviously there's a heightened amygdala response to anxiety cues and the hyper responsiveness. These are the theory, but I'll rather concentrate my saying or my presentation in a homeopathic way. Now the anxiety disorder was previously classified in that scenario. The anxiety disorder was the most prevalent as of all, as I have already told. The 15 to 20% of medical clinic patients, they were suffering from anxiety disorder, and they were basically characterized by subjective sense of unease, dread, and foreboding, and it can be primary or secondary to the other medical condition according to the DSM-4, and it was classified into this panic disorder, generalized anxiety disorder, phobic disorder, stress disorder, and obviously obsessive compulsive disorder. But right now, this anxiety disorder classification has been changed. The anxiety disorder now includes now what is basically anxiety disorder? The anxiety disorder includes a disorder that shares the features of excessive fear and anxiety, as I have already told, and related behavioral disturbances. And this disorder include, now according to DSM-5, it has classified separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder or social phobia, and obviously agoraphobia that we say, and the panic disorder, various kinds of panic disorder, and generalized anxiety disorder, substance and medication induced anxiety disorder, and anxiety disorder due to another medical condition. Now, this obsessive compulsive disorder, which was a part in this DSM-4, now it has been removed. And the acute stress disorder and PTSD, that post-traumatic stress disorder, included in the trauma and stress-related disorder, not in a part of this anxiety disorder right now, and are no longer considered as anxiety disorder, as I have told you in case of DSM-5. Now, so with time, these things actually changes. So, but we have, being a medical profession, we have to have the cue of this thing. What are the changes that are actually coming in a DSM-5 or this thing? But again, I will say that we would rather concentrate on the classification of mental disease as per the Hahnemannian way, as it has been told in the organon of medicine. Why? I'll come to that. I'll say that. Now, the prevalence of subtypes of anxiety disorder right now in our country is basically the generalized anxiety disorder, panic disorder, school phobia, separation anxiety disorder, social phobia. The school phobia, separation anxiety disorder, social phobia, these were there, but it has grown post-COVID era. Now, I'll rather say that these kind of anxiety disorder, I'm taking some time. Why? Because first we have to understand why these kind of anxiety disorder are generally growing. See, if we look at the social perspective, our society, the Indian society, is changing very fast. See, we are just following the European society or the American societies. Our families were not like that. Now we are living in an age of nuclear families. Most of our family members, they are getting separated from their parents, and obviously because of the socioeconomic condition, now both the parents have to go to job, for earning monies, and the children, either they have to be there in a creche, or if they are solvent enough, they can hire a person who can look after the children. In our ways, when we were children, we used to live in a family where there are so many family members. We have different cousins and sisters, and so many people were there, those who used to take care of ourselves. Right now, because of nuclear family, one child policy or two child policy, now these kind of social distancing and all these things, actually people are not getting time. And again, beside that, the another thing, that is the mobile phone. we don't have time to talk to each other. We don't have a time to physically meet people. We don't have time to spend our time together. We don't have our time to share our emotions with each other. So these are the things actually separating ourselves, or these are the things which are actually creating boundaries, and these are creating cocoons around us. And these are perhaps the most pertinent causes for developing anxiety, now this anxiety disorder, as I was saying, now among these anxiety disorder, panic disorder is, I'll rather first start with panic disorder. Now this panic disorder is, now there are so many causes, but as per these psychiatric causes, we can say that there is a hereditary predisposition is there, and obviously there is a familial aggregation we know in case of panic disorder. And obviously the monozygotic twins, they suffer more than the dizygotic twins. And there is a theorem of altered autonomic responses. It has been seen that genetically inherited neurochemical dysfunction that may involve the autonomic imbalances and decreased GABAergic tone, allelic pleomorphism of this COMT gene, increased adenosine receptor function, increased cortisol, diminished benzodiazepine receptor function, and then disturbances in serotonin and serotonin transporter, and obviously promoter genes, and then norepinephrine, dopamine, then cholecystokinin, and interleukin 1 beta. Now, faulty social learning. Now, this faulty social learning is another thing is there for panic disorder. And these patients of panic disorder, they have a very high sensitivity to somatic symptoms. Now, this panic disorder is again for this panic disorder, what an age of onset is typically late adolescent and early adulthood. Why? Because before this age, we usually remain protective in our familial environment, but and at this age, we generally have an opportunity to interact with the outside world. So obviously, some sort of, and obviously there are changes, hormonal changes, and obviously neurochemical changes. These things are actually happening this time. So obviously, these actually creates a fertile soil for having this kind of disorder. It occurs in an unexpected fashion and develops in an abrupt manner over a period of 10 minutes and lasts usually for an hour. And lifetime prevalence is 2 to 3%, and anticipatory anxiety and thus avoidance develops over the period of time. Recurrent and unpredictable panic attack have a distinct episodes of intense fear and discomfort associated with a variety of physical symptoms. Now, what are the physical symptoms that is encountered in case of this panic disorder? That is a palpitation, trembling, sweating, shortness of breath, dizziness, fear of impending doom of death, or paresthesia, gastrointestinal distresses, and feeling of unreality. Now, this diagnosis requires at least 1 month of concern or worry about the attacks or changes of behavior related to them. So for this, if these symptoms are persistent, and if this kind of symptomatology is experienced by one individual, and where these symptoms are there for at least 1 month, then we can say that this particular individual is suffering from panic disorder. Now, if there is a panic disorder, we have to obviously, before labeling one person that he is suffering from panic disorder, even if he has got or she has got that kind of symptom, we have to be we have to DD that thing, whether the person is suffering from coronary artery disease, or MI, or PSVT, or MVD, or respiratory disorder, or endocrinal system disorder like pheochromocytoma, thyrotoxicosis, and obviously some neurological condition. It also be mingled with some substance abuse. So we have to be very, very careful while we are diagnosing, or we are saying that this particular patient is suffering from panic disorder. The another class which is again very, very important is generalized anxiety disorder. Now, it's a variety of anxiety disorder which is basically characterized by persistent, excessive, and or unrealistic or uncontrollable worry associated with muscle tension, easy fatigueness, impaired concentration, or mind where there is mind is basically going blank. As we know, this just mind head is like empty vessel. We have such kind of symptomatology in different kinds of drugs. And obviously there is autonomic arousal and feeling of age or restlessness, insomnia. If these kind of symptomatology are there, and if 3 or more of these symptoms are there persistently for at least 6 months, then we label that clinical condition as suffering from generalized anxiety disorder. And usually this, in case of generalized anxiety disorder, the onset is usually before 20 years of age, and there is a history of childhood fear or social inhibition that may be present. Lifetime prevalence is usually 5 to 6% of patients, they have a lifetime prevalence, and risk is higher in the first degree relatives. And interestingly, family study indicates that generalized anxiety disorder and panic disorder segregate independently. Now, in case of generalized anxiety disorder, the following points are to be noted: that more than 80% of generalized anxiety disorder also suffers from major depressive disorder or dysthymia or social phobia. Comorbid like substance abuse like alcohol, sedative, hypnotics, these things are present, and it becomes worried excessively on minor matters with life disrupting effects. I think we all can understand, we all can remember some of our drugs very easily while we see this kind of symptomatology. Unlike panic attack, now this generalized anxiety disorder, the physical symptoms like shortness of breath, palpitation, tachycardia are relatively rare here. And this generalized anxiety disorder is as per the current statistics, generalized anxiety disorder is perhaps of highest prevalence in case of patients those who are suffering from anxiety disorder. Now, the other disorder which I would like to say is the phobic disorder. Now, this class of anxiety disorder is characterized by marked persistent fear of an object or a situation, and exposure to which actually causes immediate anxiety reaction. Unlike the other anxiety disorder, the phobic disorder has a specific variety. The phobic people feels anxiety only in a specific situation, not always. Now, these phobic disorders are now class. These phobic disorders, it is we can say that it is very common and affecting 7 to 9% of general population. Female to male ratio is 2:1. The full criteria of diagnosis is usually satisfied first in early adulthood, but the behavioral avoidance of unfamiliar object or people or situation can be found since early childhood. Heritability is 35 to 45%, and monozygotic twins have a greater tendency to develop phobic attack, that is 23%, over dizygotic twins, those who have a 15% chance of developing this kind of phobic disorder. Now, as a patient intends to avoid places or persons or situations of phobic stimulus, it impairs their occupational and social functioning. And the awareness that experience fear is excessive and unresponsible at a given circumstances, the specific content of phobia may vary according to the age, gender, and ethnicity. Now, this social phobia, which is now the part of DSM classification, DSM-5, as we are telling, this social phobia is characterized by marked fear or anxiety about one or more social situations, like in which the individual has to is exposed to possible and exposed to possible scrutiny by others. In children, the anxiety must occur in peer settings and not just during the interaction with the adults. The individual fear that he or she will act in a way or show anxiety symptoms that will obviously negatively evaluate them, and persistence that should persist at least more than 6 months. And the fear or anxiety or avoidance is neither attributable to the physiological effects of any substance, that is substance abuse, that should not be there, or other medical condition, or nor any medical disorder. And examples that includes of social interactions like having a conversation or a meeting with unfamiliar people, being observed while eating or drinking, and performing in front this social phobia. Apart from the social phobia, the other different phobias that we encounter during our clinical practices is, now, so very often we can see the claustrophobia, the fear of closed space. we know. And there are some drugs there we usually prescribe. Then there is hemophobia, that means fear of blood. Then acrophobia, the fear of spider. And then ophidiophobia. Then agoraphobia, that means a fear of panic attack in public. Now this agoraphobia, and we have to be very careful regarding this. With the agoraphobia, one is agoraphobia and one is there is a social phobia. Agoraphobia, that means a fear of panic attack in public, where there is a huge gathering, where there is a the public gathering is there, the patient is extremely afraid to go out in such places, like which we get in term like this is causing clinical significance or other important areas of functioning. The disturbances is not better explained by any other medical condition. So separation anxiety disorder, we can see separation anxiety disorder is very prominent nowadays. Why, as I was telling, in case of nuclear families, or where both the parents are actually working outside, while the child has to be there with someone else who is not a part of the family, or they are being taken care at the creches. In those cases, separation anxiety disorder, actually we can see the people, these kind of children, those who are coming to our OPD, and basically those people are doing in the IT jobs, IT professional, their children mostly develop this kind of separation anxiety disorder. And also in case of adult separation anxiety disorder, after if there is any kind of history of a relationship crisis, or if there is mostly in relationship crisis. Nowadays relationship crisis is very prominent in adult age group, no? So this kind of separation anxiety disorder we can find this kind of people. So recurrent excessive distress when anticipating or experiencing this separation is there. Worry about losing a major attachment figures, or about possible harm to them. Worry about experiencing an untoward event. Persistent reluctance or refusal to go out is a very prominent symptom. Excessive fear of or reluctant about being alone. These people, they don't like to live alone. Persistent reluctance or refusal to sleep away from home and without being near or major attachment figures. Now, repeated nightmares is another prominent symptomatology of this disease or disorder. Repeated complaints of physical symptoms like headache, then stomachache, nausea, vomiting, this kind of symptomatology is very prominent in this kind of patient. Now, separation anxiety disorder, why this kind of separation anxiety disorder is basically there. Now, the changed environment and the stress, obviously, as I was saying, overprotective parents, family members with anxiety or other kind of mental disorder. And separation anxiety disorder is again found in case of where there is the family trouble with single mother or single father. A child is being is taken care with by a single mother or single parent. There is this kind of or divorce, increased number of divorce nowadays. Now this kind of thing is actually creating separation anxiety disorder in case of children. And obviously in case of adult, as I have already told, that because of the changed socioeconomic condition, changed environment, need of life, now because of this thing, so fast life, fast pace in our life is actually creating problem in case of keeping relation with each other. So that is why, and we are mostly where the person is mostly emotionally dependent on each other, so these kind of people, they usually suffer from separation anxiety disorder. Now there's a selective mutism is another condition. Now these kind of mostly found in case of children. These people, those who are suffering from selective mutism, they usually do not they portray while they are in an environment which is not familiar with, or in an environment to which these children are not familiar. Like if there is a is certain social situation, or they are going to in a school, they are not talking. They are not, they can easily communicate with their parents, with their known persons. They can easily communicate at their home, at their I mean with the person those who are familiar with. But when he is outside, there's a failure to speak in certain social situations despite the ability to speak, which is very important, and in more comfortable situation. Now, like a meeting with new people versus home with family. In home with family, they can speak very well, but while they are encountering a new people, they are not speaking. Now, use of gestures, instead of saying, they are using more of a body language. Okay, where instead of communicating verbally, they are communicating with body gestures or non-verbal communication. Now, like in case of heightened anxiety with expectation to speak, and obviously there is an intense distress that increases with routine activities and relationships. These are things are there. And according to DSM-5, the persistent failure to speak in specific social situation but freely with others, in others condition, that means the conditions to which the child is familiar, if that thing is there for more than 1 month, then we can say, according to DSM-5, this particular person or child has selective mutism. So it is a rare anxiety disorder. That's why we really don't get this kind of children very often. But yes, we do get. Now, selective mutism, another I'll say there. It's not selective mutism, but sometimes people or the children, those who are exposed to different types of languages. This I'm saying from my clinical experience. We usually see children from of in whom the parents are, I mean, doing the transferable job, or in whom the child are or the in whom the parents are basically from IT sectors, those who are coming to our hospital. There is a problem. The different language problem is there. See, I can explain the situation like this. This perhaps the children's mother, child's mother is Maharashtrian, father is obviously a Bengali, and obviously why when these two people are talking with each other, obviously they are using another language of communication like Hindi in home, while they are talking with people those who are coming to their home, they are using another language, Hindi. Or independently, when they are communicating with the children, either the mother using Maharashtrian, the father using Bengali, or they are their the grandparents or those who are coming to them, they are using a different language. So child becomes very confused, what language is my own language? And in these situations, I have seen children, they have stopped talking, and they have started using their body gesture, and they have started non-verbal communication more. It's not like that they cannot speak. Usually the parents say that my child used to say I mean, according, there is no developmental delay, there was talking, there's a monosyllabic word he used to use, or she used to use disyllabic word, and they used to say, but suddenly he has stopped talking, because in school he is or she is speaking English, at home she is getting different kinds of language. These kind of thing actually happen, but this is not selective mutism. This is perhaps the child becomes very much confused what language he or she should pick up. But this selective mutism is such when the children can speak freely at home with his parents or those who are there in his family. But when this particular child is put outside, there he is under trouble, he is not able to speak, he is not free to speak. That is a condition we say it's a selective mutism. Now, there's an anxiety disorder prognosis. The high rate of comorbidities are there. Obviously, the morbidity or mortality through neuroendocrinal, neuroimmunomechanical, neuroimmunomechanism, or direct neural stimulation is there. There is an increased risk of various kinds of diseases like cardiovascular diseases, various kinds of, the most important thing is that because of this anxiety, nowadays we can see this social phobia, social anxiety disorder result in significant functional impairment, and the severe anxiety disorder may complicate by the situation with suicidal tendency or inclination to suicide. So this kind of thing we can easily see. The panic disorder was associated with suicidal attempt, and the odd ratio, which has been calculated, that is 18, is compared to the population without psychiatric disorder. That means the in a population who has this kind of panic disorder, they have a chance of committing suicide 18 times more than people, those who are living in a population where there is no psychiatric disorder. So the acute stress may play a role in producing suicidal behavior, and the presence of any anxiety disorder, phobia included in combination with the mood disorder appears to increase the likelihood of suicidal attempt compared with mood disorder alone. So the what actually it means, that the anxiety disorder itself can cause any other corporeal disorder, like cardiovascular system disorder, like endocrinal disorder, like a the neuroendocrinal disorder, or a neurological disorder. Or the most important that we must concentrate is that because of this anxiety disorder, the mood disorder is there, and in mood disorder there is a the depressive mood disorder. And this depressive mood, those who usually suffer from depressive mood disorder, they have a very high risk of developing this suicidal attitude and suicidal, and the committing suicide. So that is why this anxiety disorder is very, very important. And obviously, apart from any other thing, the if we can treat the anxiety disorder very in a very early phase, or we can get this anxiety disorder very early phase, we can very effectively treat that thing. Now, the thing is that DSM-4, DSM-5, so many things, so many differentiation, so many varieties of symptomatologies are there. The symptomatologies are usually changing with time. We are labeling the disease condition, we are adding something with time, we are discarding something with time. But if we really want to treat this mental disease homeopathically, we have to go to the organ of medicine, our Bible, from aphorism number 210 to 230. In these aphorism, our master has explained this disease condition in elaborately. And everyone knows this kind of disease condition. These aphorisms, aphorism 2000, 200, 215, 216, and obviously then which is this is actually, we say it's a somatopsychic disorder. And obviously there is this 221, which actually deals with the mental disease suddenly appearing as an acute disease. And obviously 224, where there is a doubtful origin, whether it's because of the corporeal disease or it's a psychological disease entirely, or then it's a psychosomatic disorder. 5. Now, we know all these things, but why I have kept these things is that whatever we learn from practice of medicine, whatever we learn from psychiatry, but we have to assess that thing. We have to perceive the entire mental disorder or anxiety disorder in this way. Otherwise, we will not be able to treat these cases. Now, since there are so I'll discuss my cases. I know I cannot give the details of my cases because 2-3 reasons. We have some cases in pipeline for publishing, and I do not have all these cases where I cannot have the written concept.
Excuse me, sir. How much time you need, sir?
But I'll say this thing. Yes, sir.
How much time you need, sir? We have to finish by 9 o'clock. We have a discussion for 10 minutes. I think if more topic is there, you can have another session. What is your opinion, sir?
Old child, she was taking us while she having was there in every morning while she was suffering from 2 years at a stretch. She was by various kinds of pediatrician and various and other doctors, and obviously after doing a lot of taste and everything else, everything was normal, nothing pathological was there in that child. But she was taken to a homeopathy hospital, and while we are examining a child, it is very important as a clinician to develop a rapport with the child. It is extreme. You cannot communicate with the child if you cannot bridge the, if you cannot mix with the child uh, as a child, so that he or she can develop a confidence on the doctor. Until unless we can do that thing, obviously he or she not, the patient will not open up to us. And that is why we say, Dr. Kent has said, a well taken case is half cured. So while examining that thing, what we found is that the child was under the situation was that the child was getting ready in the morning. She was having her breakfast. While she was entering into the school bus, she used to throw up everything what she have taken in the morning. But on Sunday, on holidays, on other days, she do not do that kind of thing. Her mother told us she never vomits out, she never throws up while she was going outside during the holidays, while she was riding a bus or riding a train or riding a car. While she is not going to school, she is not having any such thing. After asking the child, what we found that that particular child has separation anxiety. She was extremely afraid while she was going to school, because of one, she was not there with her parents, and obviously the school teachers, one of the school teacher was very strict, and she was scolded one day, and following that she started that thing. And the drug which actually was given was sulfur. This why sulfur was given, obviously this is a symptomatology of the flaring of the sora. And the symptomatology, obviously sulfur symptomatology, we all know what the symptomatology of sulfur, so that's why I have not put all those symptoms. So she was given sulfur 202 doses, and that dramatically scenario, she stopped vomiting. And obviously, apart from giving sulfur, we advise that the parent to go for a counseling, parental counseling, not the counseling outside. And obviously we ask the parent to communicate with the school people so that she can feel free at school. And obviously what we have asked the parent, that they should give some more time. If they cannot, then obviously the grandparent should give more time, and she should feel secured. And obviously after giving sulfur 2 doses in 2 consecutive morning, there was placebo for 6 months, and thereafter we gave her sulfur 1 mg. And since that, she never throws up. The vomiting was completely gone. Another case was there. It was Mrs. TC, and a 72 years old person. She's a retired school teacher, and she came with the symptomatology of effort dyspnea and heaviness feeling in the central chest. The TMT was positive for coronary artery disease, but I was negative, and coronary angiography was done. It was negative, but the USG of whole abdomen, it was obviously within normal limit. There was nothing else, and she was diagnosed as suffering from microvascular angina or syndrome X. Now, why she was having that kind of thing, when we asked her during the time of discussion, we found that she had not a very good relationship with her husband. She was a teacher, but after retirement, she is not allowed to do her the teaching, and she loves to teach, and she was not allowed to do that thing at her home. She is extremely fond of singing. She is not allowed to do that kind of thing. She was not allowed to go for singing. So whatever her suddenly she felt that she is caged in her home. But thing is that she was so modest that when I asked, why don't you say something? At least with discussion, you can resolve this problem. She just told me one thing, that it is my upbringing that holds me back to confront with my husband. So that is the thing that give us the clue of a reserved displeasure. And she was given staphysagria. Staphysagria 1 mg was her prescription, and after giving staphysagria, that effort dyspnea, that heaviness feeling of chest was gone, and it is not there. She is still under our treatment. And obviously after giving staphysagria, our constitution was obviously is calcarea carb. We are waiting to give her calcarea carb, obviously, if the symptoms correspond, and obviously we will conclude the case with this any antipsoric, any other antipsoric that will be indicated in time. But the simple staphysagria, the simple that reserved displeasure, that created a stress within her, and that anxiety, that stress, that she is not able to come out, she is not able to do her job, she is not able to live the life in her own way, now created this kind of problem. So this is another anxiety. So this is anxiety giving a somatic symptomatology, and that is the way we homeopath we usually go. And obviously I must say, we all homeopath we should go in that way. Now another case is Mrs. A, 62 years old female, and she was diagnosed to having IBS. She was having this IBS, and since her husband has passed away, and she is very afraid in everything in daily life, and she's very, actually she was everything was, when her husband was alive, she was she didn't do anything else. Her husband used to take everything, inside home, outside home, everything was taken care by her husband. Now suddenly she is at loss, and obviously her children are not staying with her, and what she does is speaks about her complaint repeatedly. She changes her topic of discussion spontaneously, and if one single symptomatology, she will tell you, when you are encountering the patient, she will tell you 10 times, 15 times, like that, and she used to change her topic. And obviously, because of this great loquacity is a manifestation of internal anxiety. And depending on that internal anxiety and this great loquacity, changing of topic, and this kind of thing, this great stress, she was given, and from the other symptomatologies, she was given lachesis. And after lachesis, obviously she got some, this IBS was somewhat less. And obviously, following lachesis, we had, as the symptom corresponded, we gave her sulfur. After giving sulfur, she is not having IBS. She is under treatment for last 8 to 10 months. She is not having IBS anymore. She is rather, at least, not that kind of anxious anymore. And what we have suggested, go for yoga, or go for any kind of social interaction with other people, and obviously to create some psychological support group, to join that kind of psychological support group, what she has done, and she is better right now. This another is separation anxiety. Another beautiful example of separation anxiety, Master AB is a 6 years male child. He used to suffer repeated attack of fever. His father is a businessman. Whenever his father is going outstation, the child develops fever. When initially the child, the parent came to us, because the mother took the child to ask for fever, we have seen, we prescribe all those same the drugs that we usually prescribe in case of fever, but none of them worked properly. Every time he was developing fever, and obviously we go for a thorough pathological investigation. There was nothing else. And obviously, on a proper case taking, what we found, it is his father who told us that whenever I'm going out and he is having this kind of fever, so we gave him Ignatia. And after that, marvelously, after that Ignatia, the child did not develop fever. Even after while his father was not with him, beside him, he was going outstation. And obviously, following Ignatia, we obviously completed the case with another indicated antipsoric, and he was given calcarea carb. And after calcarea carb, he is free from that kind of fever. And now this child is almost is a 16 years old child, and this time he is going for a board exam. He's not having that kind of fever. He never suffered that kind of fever later. Now another case, so Mr. PD, 56 years male, and there's a complaint of prolonged dry cough for at least 3 months. He used to have this anti-allergic drug by our allopathic counterpart, and there is a history of conflict with office boss. And there's a obviously this is this we found on the on repeated case taking, and what he came with prolonged dry cough. There is no expectoration and nothing else. IgE was normal. Eosinophil count was entirely normal. Lung was chest extra CXR was absolutely okay, and obviously FEV1 and VCY was normal, and obviously HSCT was normal. Everything was normal, but what he had, this prolonged dry cough, and that actually started after having conflict in his office. And following that conflict, this is another case where we got success with staphysagria. We gave him staphysagria, and after having this staphysagria, he actually came out of this thing. And we have so many cases of anxiety.
Excuse me, sir, we have to wind up now, sir.
Pardon, sir?
It's 9 o'clock now.
Oh, sorry.
Am I audible, sir?
It's 9 o'clock. Yes, am I audible, sir?
We have 10 o'clock, sir. Am I audible, sir?
Okay, so we have. Yes, you are audible, sir. Sir, okay, one last word. This is last case. This I have seen today itself. There's another case where there is a recurrent, attack of hematospermia, and the patient he has this extreme anxiety, and it is under treatment. And after having sulfur, only sulfur, this patient is improving. And obviously, we are documenting all these cases, and we have a plan of publishing these cases in near future.
Thank you, sir. I think it's time to wind up the session.